Welcome back to Clinical Anatomy for PA students. Today we'll be talking about the pelvic viscera. This is lecture 1 in a 3-part series. The pelvic organs include the rectum, the caudal or inferior parts of the urinary tract, as well as the reproductive organs. This lecture will focus on the bladder and the prostate. The urinary bladder is a hollow, muscular-walled organ that rests on the pelvic floor in the pelvis, just inferior to the peritoneum. The urinary bladder's anterior portion lies directly superior to the pubic bones, and the apex, which is the interior-most pointed region, points towards the superior aspects of the pubic symphysis. While the urinary bladder rests on the pelvic floor, as it fills with urine, it expands and the top rises up into the greater pelvis, which is technically the abdominal cavity. So while it sits in the pelvic cavity, as it fills, it rises up from the true pelvis into the greater pelvis, or from the pelvic cavity up into the abdominal cavity. And when it's completely full, the bladder can actually rise as superior as the umbilicus. So it can rise to the level of the umbilicus. The bladder has 4 surfaces and 4 parts. The surfaces are the superior surface, 2 inferolateral surfaces, and a posterior surface or base. The superior surface is this surface up here, right at the top. The 2 inferolateral surfaces are around the sides and working down towards the bottom here, and then on the opposite side as well. And then the posterior surface is over here, the back surface, which wraps around the base. The 4 parts of the urinary bladder include the apex, the fundus, the body, and the neck. Let me erase this. The apex, which is traditionally a pointed end of the organ, is this anterior-most pointed portion of the urinary bladder. And again, the apex points towards the top of the pubic symphysis, the area in the very front of the pelvis where the pubic bones meet with that fibrocartilage pad. So this pointed part right here is the apex of the bladder. The fundus is the base, posterior portion of the bladder, opposite the apex. The base is a convex curve, or sorry, the fundus. The fundus is a convex curve, just like it is in the stomach as well. It's that extra like rounded storage area on top of the stomach. This is also a convex rounded area. It just happens to be in the back or the posterior portion of the urinary bladder. So the apex is the anterior pointed part. The fundus is the posterior convex curved part. In females, the fundus, or the back of the bladder, is closely related to the anterior wall of the vagina. So what that means is that in females, the bladder is directly anterior to the vagina. It also happens to be inferior to the uterus, which we'll see on the next page. So in females, the bladder is anterior to the vagina, and inferior to the uterus, which is why pregnancy is associated with a urinary frequency, having to go pee all the time, not being able to fill the bladder very much because the uterus sits right on top of the bladder. So as the uterus grows, it compresses the bladder. Again, we'll see that on the next slide. In males, the fundus of the bladder, or the back posterior base of the bladder, is related to the rectum. So in males, the bladder is anterior to the rectum. So there's an extra passageway that's present in females, being the vagina. In females, it goes from the rectum to the vagina to the bladder. In males, it goes directly from the rectum to the bladder. So the apex is the pointed anterior portion of the bladder, and the fundus is the curved posterior portion of the bladder. The body is the area between. So all of this area that's in between is the body of the urinary bladder, the major portion or major mass of the bladder. The neck is the area where the fundus meets the inferolateral walls. A good way to define the neck is this thin inferior region that leads into the urethra. So the neck is a thinner inferior region where the bladder empties into the urethra. Here we can see the urinary bladder in females and in males. This is the female, obviously, because we see the uterus right here. And we see ovaries right here. That means that this is the urinary bladder in the female. You remember I said that the uterus sits directly on top of or directly superior to the urinary bladder in females. And then directly posterior to the urinary bladder is the vagina. So here you see the vagina. It's not shown on this picture, but posterior to the vagina, very closely related to the vagina, would be the rectum. Looking at the urinary bladder in the female, this is the anterior side, and this back here is posterior. We know that because of the position of the vagina, but also because this is the apex, the pointed anterior portion is the apex, and then the base or fundus would be back here. The neck of the urinary bladder is where it thins right here, and then it empties into the urethra. Over here, in the male, you can see this is the urinary bladder. And directly posterior to the urinary bladder in males is the rectum. So this is the rectum. Inferior to the urinary bladder in males is the prostate. So this right here is the prostate, which we'll talk about later in this lecture. And you can see that the urethra in males passes directly through the prostate and then continues down the penis and then exits the penis. So the urethra is much longer in males because it has to go down the length of the penis. Also posterior lateral to the male urinary bladder, we have seminal ducts or seminal glands, which you see right here, which are not present in the female urinary bladder. The wall of the bladder is formed mostly by the layer of muscle that's referred to the detrusor muscle. So most of the bladder wall is the detrusor muscle. Towards the neck of the bladder, the detrusor muscle forms the internal urethral sphincter. In males and females both, the internal urethral sphincter provides involuntary control of urine flow from the bladder into the urethra. So the internal urethral sphincter is involuntary. You don't consciously control that. It's the initial sphincter that relaxes in order to allow urine to escape the bladder. The external urethral sphincter is a striated skeletal muscle that you consciously control. Both need to relax in order for urine to be released from the bladder. In men, the internal urethral sphincter has an additional function. In men, the internal urethral sphincter contracts during ejaculation. Now, remember that the urethra allows urine to exit the bladder, but in men, the urethra also allows for semen to exit the penis, exit through the urethra to be ejaculated. So the urethra is a passageway for both urine and semen or ejaculate. During ejaculation, the semen should go through the urethra and exit the penis at the urethral orifice, the external urethral orifice. We don't want the semen to go into the bladder. So the internal urethral sphincter contracts during ejaculation, and this is to prevent retrograde, or backwards, flow of semen into the bladder. And I'll show you that on the next picture. But you have like the bladder, and the urethra passes through the prostate gland. And then remember, in the prostate gland, there's the ejaculatory duct that merges with the urethra. So the internal urethral sphincter is like up here. And what happens is the semen comes through the ejaculatory duct, and we want it to go down the urethra. Okay, we want it to go down in this direction. We do not want it to go up into the bladder. So the contraction of the internal urethral sphincter stops that so that the semen just exits. It doesn't go retrograde up into the bladder. Obviously, this function is not present in females because females only allow urine to exit through the urethra. The trigone is an internal structure of the bladder wall. When you open the bladder and look at the posterior and inferior aspect of the bladder wall, there's an area of the mucosa that's relatively smooth. The majority of the bladder mucosa has rugae or folds in the mucosa, and those just allow for stretching of the bladder. So as the bladder fills, those rugae disappear or flatten, just like we see with the rugae or gastric folds in the stomach. The trigone, though, this triangular area, is relatively smooth, and it's formed, the 3 points of the triangle. The top two are formed by the ureteric orifices. The ureteric orifices are the areas where the ureters empty into the bladder. So the ureters, remember, are carrying urine from the kidneys down to the bladder. They enter in at the back, inferior and posterior aspects of the bladder. The ureteric orifices, or the openings where the ureters come in, are encircled by loops of the detrusor muscle. And those loops they form a sphincter around the openings into the ureters. So when the bladder contracts to release urine out the urethra, these circles of muscle also contract. And so when the bladder contracts to squeeze out urine, that squeezes these ureteric orifices closed. And that's important because when the bladder contracts, we want urine to go out through the urethra. We don't want urine to go backwards, back up into the ureters. So the top two corners, if you will, of the trigone are formed by the ureteric orifices, the openings into the ureters, and the inferiormost, or this third corner or point of the triangle, is the internal urethral orifice. That's the opening into the urethra. Okay, so here we see a female, and this is a male. I know that this side is a male because there's a prostate. This is the prostate gland. And there's no prostate in the female. So you see the bladder on both sides. The bladder wall is formed mostly of muscle, and that muscle is the detrusor muscle. And the detrusor muscle is present in both. The trigone is this kind of smooth shaped or smooth triangular shaped area. And that trigone acts as, it's kind of like a funnel directing the urine down into the urethra. The folds that you see present in here are rugae. These top two little holes, these openings right here, those are the ureteric orifices. The openings, the ureters, where the ureters empty into the bladder. The inferiormost part of the bladder, this is the neck of the bladder, is where it thins right here. And at the neck of the bladder is where the internal urethral sphincter is. So the detrusor muscle forms the internal urethral sphincter around the neck of the bladder. This opening right here into the urethra is the internal urethral orifice, where the urethra opens out, like so in the female, it's really short. Right here is the external urethral orifice. In men, you can see that the urethra comes down and goes into the penis. And this is going to be, we'll talk about it in a second, but there are multiple parts to the male urethra. The spongy urethra is the part that goes through the corpus spongiosum of the male and the penis. So the male penis extends much longer than, the male penis. There is only a male penis. The male urethra is much longer than the female urethra, so we don't see the whole thing on here. I'm trying to think what else I've missed. Oh, the external urethral sphincter is right here, and then here, and that gives us voluntary control of the release of urine. A suprapubic cystostomy is when a stoma is created or an opening is created into the bladder, and the entry into the bladder is from a suprapubic position. So entering the bladder without going through the urethra and without having to traverse the peritoneum or open the peritoneum in any way. The reason that this can be accomplished is that, remember, as the bladder fills, it rises out of the true pelvic cavity or out of the true pelvis and up into the greater pelvis. So the bladder rises into the abdominal space, and it rises into the extra peritoneal fatty tissue, or the tissue outside of the peritoneal cavity, in the enterolateral or just deep to the enterolateral abdominal wall. So the bladder rises up anterior to the peritoneal cavity, just deep to the muscles of the enterolateral abdominal wall. So it can be entered relatively easily, again, without having to go through the peritoneum, without having to access the peritoneal cavity at all. This is done to place indwelling catheters or to insert surgical instruments during a procedure. For example, reinsertion of a ureter. Or other surgical procedures that require ureter manipulation then can be done accessing via the ureter, which we'll talk about in just a second. The bladder can rupture due to a pelvic fracture. So fractures of the pelvis can cause the bladder to rupture. Rupture of the posterior bladder, so by the fundus, results in urine passage into the perineum. If the superior bladder ruptures, for example, when there's injuries to the inferior abdominal wall, that can affect the superior-most portions of the bladder. In this case, the peritoneal membrane frequently tears as well. Remember, the bladder sits just inferior to the peritoneum. So if the superior-most portion of the bladder is being injured, typically the peritoneum can be injured as well. In this case, urine can leak into the peritoneal cavity. Right? So rupture of the posterior or fundus of the bladder, the urine passes down into the perineum. If the superior portions of the bladder rupture, the peritoneal membrane typically does as well, and urine can pass superiorly into the peritoneal cavity. Cystoscopy is a specific type of endoscopy where we're visualizing the internal aspects of the bladder with a specific endoscope. In this case, it's a cystoscope because it's the bladder that we're entering and visualizing. A cystoscope is inserted into the urethra and fed through the urethra into the bladder. It has a light present on it that allows us to view and visualize the internal walls of the bladder, as well as the 3 orifices of the bladder. That would be the 2 ureteral orifices and the 1 internal urethral orifice. Again, as well as the bladder wall itself, the mucosa itself. Attachments can also be utilized with the cystoscope. The attachments allow for grasping and manipulating, cutting or removing, for example, if we need to get a biopsy, or cauterizing vessels to stop a bleed. There's various different things that can be done with the attachments of the cystoscope. Now we'll continue on with a discussion of the urethra. Remember that the 2 ureters carry urine into the bladder, and the single urethra carries urine out of the bladder to the exterior of the body during urination. There are great structural and functional differences between the male and female urethra, so we will talk about them separately. We'll start with the female urethra, which is a bit simpler. The female urethra is much shorter than the male urethra. It has a lesser distance that it has to traverse before it gets to the external portions of the body. The female urethra exits the inferior borders of the bladder at the neck of the bladder, and it passes anteriorly and inferiorly from the bladder. So it descends and it slightly goes forward a little bit as it descends the body. The urethra descends anterior and parallel to the vagina. So if you look at this picture right here in the bottom right, you see this is the urethra and this is the vagina. So they pass just parallel to each other as they go towards the vestibule of the vagina. The urethra passes through the pelvic diaphragm, and we see that there are loops of muscle from the pelvic diaphragm circle around the urethra. Forming the external urethral sphincter. Sorry, I'm running out of room. So where the urethra passes through the pelvic diaphragm, the muscles from the pelvic diaphragm loop around the urethra and form the external urethral sphincter. This external urethral sphincter is skeletal muscle, and it is voluntary. Right? We have conscious control of this. The female urethra ends at the external urethral orifice, the external opening into the urethra, and this is in the vestibule of the vagina. If you look over here, the vestibule of the vagina is like just this opening right here, this open area, right before you go into the vagina itself. So the urethra opens up into the anterior portions of the vestibule of the vagina, just posterior to the clitoris, which you see right here. So it's between the clitoris and the actual vagina itself, the vaginal orifice. Periurethral glands are present in the superior urethra, and they have ducts that distend and open near the external urethral orifice. These periurethral glands are homologous with the male prostate. So during development, the tissue that forms them is the same tissue that would form the prostate. So during development, the development kind of splits. And in males, it turns into the prostate. In females, it turns into the periurethral glands. So here you see the bladder. The internal urethral orifice is the entry into the bladder right here. And that's where the internal urethral sphincter is formed with muscle from the detrusor muscle that just loops around. The urethra descends and passes through the pelvic diaphragm. And the pelvic diaphragm then wraps around the urethra to form the external urethral sphincter. The external urethral orifice is just the opening into the urethra. And again, that is in the vestibule of the vagina, so it's enclosed within the labium minora and labia majora. And it's just anterior to the vagina and just posterior to the clitoris. The male urethra is much longer than the female urethra, and it conveys urine from the internal urethral orifice, which exits the bladder, down the length of the penis to the external urethral, the external urethral orifice, which is the exit from the urethra in the glans penis, the very terminal portion of the penis. The male urethra conveys urine out of the bladder, from the bladder out of the body, but it also provides an exit for semen during ejaculation. The male urethra is divided into 4 parts. The intramural urethra is the short initial segment of the urethra. This is the area that's surrounded by the internal urethral sphincter. Again, the internal urethral sphincter is involuntary smooth muscle. It's innervated by sympathetic fibers. Which are part of the autonomic nervous system, which we do not control. This internal urethral sphincter has to be relaxed in order for urine to exit the bladder. But remember, it contracts during ejaculation. Contracts during ejaculation. Oops. And the reason that it contracts during ejaculation is to prevent retrograde flow of semen into the bladder. The intramural urethra then is that first part that goes through the internal urethral sphincter. The next section is the prostatic urethra. The prostatic urethra goes through the prostate. This is the part of the urethra that accepts semen from the ejaculatory duct during ejaculation. The intermediate or membranous urethra is the third segment. This is the section that's surrounded by the external urethral sphincter. The external urethral sphincter is skeletal muscle, right, which is voluntary. We consciously control it, and it's innervated by somatic motor fibers. This is the major muscle that maintains continence, or our ability to control the release of urine from the body. stimulation of both sphincters has to be inhibited in order for urination to occur. So both sphincters have to be relaxed in order for urine to exit the body. The final segment of the male urethra is the spongy urethra. This is the longest segment of the urethra. This section traverses down the penis in a section of the penis called the corpus spongiosum. We'll see that the penis has two little areas or chambers that are corpora cavernosa, and then the corpus spongiosum, which is where the urethra passes. Here we see the male urethra. You can see the bladder, and then the urethra first at the bladder neck, going through the internal urethral sphincter, then going through the prostate, then going through the external urethral sphincter, and then entering the penis. And here it goes down the corpus spongiosum, all the way down to the glans penis, and then ends at the external urethral sphincter. This is just color-coded into the different segments. Here's where the internal urethral sphincter is, the prostate, external urethral sphincter, and then down through the corpus spongiosum. Here you can also see, we've already covered the testes and ductus deferens and all that, but here you see the testes, the epididymis around the back, and then the ductus deferens. The ductus deferens, remember, comes around to the posterior lateral sides of the bladder, and then the seminal gland is right here, and there are secretions from the seminal gland, and then sperm come from the ductus deferens, and they merge into this ejaculatory duct. And you can see the ejaculatory duct coming down through the prostate, and it enters into the prostatic urethra. So when ejaculation is occurring, the ejaculate or the semen comes down the ejaculatory duct and enters into the prostatic urethra. The internal urethral sphincter, which is up here at the bladder neck, contracts so that the ejaculate does not go up into the bladder, and instead the ejaculate comes down, the semen comes down the remaining portions of the urethra and exits the penis via the external urethral sphincter. The remainder of the lecture will focus on the prostate gland. The prostate gland is a gland that's present only in men, or males, and it's a gland that surrounds the prostatic urethra in men, inferior to the urinary bladder. 2/3 of the mass of the prostate is glandular, and 1/3 of it is fibromuscular, muscles mostly in the anterior portion of the prostate. The base of the prostate is the superior surface, or the top that's related to the bladder, and the apex is the bottom that's down near the external urethral sphincter. The anterior surface of the prostate is again where we mostly have the muscle fibers, and this is in the retropubic space. So this is right behind the pubic bones. The posterior surface of the prostate relates to the rectum. It's just anterior to the rectum. This posterior surface is the surface that's most easily palpable during a digital rectal exam. The inferolateral surfaces of the prostate are related to the levator ani muscle, which is the muscle that forms the pelvic floor. And we see kind of generic pictures of the prostate just to give us an idea of the overall relationship between the prostate and some of the surrounding structures. So here we see the male urinary bladder. Actually, let me do red. Here we see the male urinary bladder, and just inferior to that is the prostate. So the base of the prostate is the superior surface that's related to the urinary bladder, and the apex is the inferior, somewhat pointed surface, which is related to the external urethral sphincter, which you see here. The lateral surfaces of the bladder, you can see related to the levator ani, the muscles that form the majority of the pelvic floor, which we covered in the last lecture. Here, again, you can see the urinary bladder and the prostate below. In this picture, however, you can see the ejaculatory duct merging with the prostatic urethra. And then again, you can see the urethra exiting the prostate and just below that going through the external urethral sphincter. Also over here, this is the anterior and this is the posterior. You can see directly posterior to the rectum, posterior to the prostate is the rectum. And so the anal canal, and then the rectum. The prostate is broken up into multiple different zones, regions, lobes, areas. It's broken up in a lot of different ways. This shows some of the different zones of the prostate though, and this is nice because it shows us where the problem with the prostate is with different conditions. And the two most important of these that we'll look at are BPH, benign prostatic hypertrophy, and prostate cancer. So here you see this is anterior and posterior. Right up here superiorly, obviously you have the bladder, then inferiorly we would have the external urethral sphincter, and then the urethra would continue into the corpus spongiosum. So looking at the prostate gland itself, this anterior zone of the prostate is muscular. There's mostly muscle fibers up there. The other portions are glandular. This transitional zone, you can see that this is the area that's surrounding a large portion of the urethra. This is the area where about 20% of cancers are. However, this is the area where we typically have a lot of hypertrophy and where the symptoms occur because of that hypertrophy and BPH. BPH, benign prostatic hypertrophy. Hypertrophy is like overgrowth. So you can see if there's overgrowth here in this zone, that would start to squeeze the urethra, right? And that can interfere with flow through the urethra, which is why it's difficult to release urine in BPH because the urethra gets compressed with that overgrowth of the prostate. The central zone you see surrounding the ejaculatory duct, not a very common site for cancer either. The peripheral zone here you see is a very common site for cancer. That's the most common area for cancer to occur. And if you look at this, you see that this is more posterior. And remember we said back behind the prostate is the rectum. So back here is the rectum. So you can see how during a digital rectal exam, or where the fingers are used to examine or go into the rectum and palpate the rectum and the prostate, you can see how when palpating the prostate, you would be palpating the portions of the prostate where cancer typically develops. Okay, so speaking of benign prostatic hypertrophy or overgrowth of the prostate gland, which is benign. It is a non-cancerous overgrowth of the prostate. It is common in men after middle age. Again, growth of the prostate that is non-malignant. It is not cancerous. When the prostate overgrows or is hypertrophic, it can project into the urinary bladder and can compress the prostatic urethra. This obstructs urinary flow and results in weak stream, difficulty emptying the bladder, so typically an incomplete emptying of the bladder. And this causes urinary frequency, so having to empty the bladder constantly and having that urge constantly because it never quite empties all the way, and then having difficulty actually emptying the bladder as well. Here, this is normal, healthy prostate. Okay, and then over here, you can see benign prostatic hypertrophy. The prostate is overgrowing. You can see it's starting to compress or grow up into the bladder, and it's absolutely compressed the urethra. So it's difficult to release urine from the urethra. As a result, there's always urine in the bladder. It's difficult to empty all the way. And as you can see that the bladder wall has thickened. The reason for this is, remember, the bladder wall is muscular and it contracts to empty urine or squeeze urine from the bladder. When there's compression in the in the prostatic urethra, when the urethra is compressed, it's difficult to get urine through it, right? There's obstruction of urinary flow. So the detrusor muscle is working extra hard to try and get that urine out. So as a result of there can be overgrowth or thickening of the bladder wall as well, of that detrusor muscle. Prostate cancer is a type of cancer that's common in men over the age of 55. Most frequently, as we saw in the picture, prostate cancer is present in the posterolateral prostate, so in the back and kind of lateral aspects of the prostate. This is the area that's easily palpated with a digital rectal exam. So digital rectal exam can give a clue or a hint that there might possibly be prostate cancer present. A malignant prostate typically feels hard and irregular upon palpation. Prostate cancer typically does not metastasize until very late stages. In late stages or advanced stages, it might metastasize initially to the iliac and sacral lymph nodes that are in the area, and then after that, distant nodes and bone. But again, it does not typically metastasize until very late. A prostatectomy is removal of the prostate gland, and this can be done at prostate cancer or severe BPH to remove that diseased prostate. During the prostatectomy, the fibers that are involved in penile erection can be damaged, so impotence is a major concern. To avoid this, only parts of the diseased parts of the prostate can be removed. Specifically in BPH, there's a procedure that allows you to remove only the hypertrophied parts that surround the urethra. This procedure is referred to as TURP, T-U-R-P. It is a transurethral resection of the prostate. And again, that's for BPH. I'll show you on the next slide. So here we see the TURP that I was just talking about. To get your bearings, you see the bladder. Back here's the seminal gland. So you see the ejaculatory duct coming into the prostate. This whole thing is the prostate. The urethra. Over here, you see the urethra going up towards the bladder. And this is prostatic tissue that's all overgrown. And it's all overgrown and completely compressed this urethra, so it's really difficult for the urine to flow through that urethra. With TURP, transurethral. So the tool is put through the urethra, or threaded through the urethra up into the prostate, the prostatic urethra, and it cleans out or removes the prostate tissue that's compressing the urethra. And that opens up urinary flow without removing the entire prostate. And that lessens the chances of resulting in impotence. Over here, you see a digital rectal exam. Again, this is important in kind of giving us a clue that prostate cancer might be present. An easy exam to tell us that prostate cancer is present, and cheap exam. Here you see the male's urinary bladder, and then the prostate. We said that prostate cancer is typically in the posterolateral portions of the prostate, so back in these regions of the prostate. And then again, just posterior to the bladder and prostate is the rectum. So by inserting a digit into the rectum, you can palpate the regions of the prostate where cancer is most likely present. And again, a malignant prostate will feel hard, irregular. All right, that is it, guys. In part 2, we will continue on with other viscera or other organs of the pelvic cavity.